Welcome to the Future of Health Summit. We are delighted to have you join us for this event in Washington and look forward to your participation throughout the day. To open the program, please welcome to the stage Executive Vice President, Milken Institute Health, Esther Krofa.
Good afternoon. Good afternoon. All right. Good afternoon, everyone, and welcome to the 2025 Future of Health Summit. Whether you're here in the room or watching online, thank you for joining us. We're gathered today under the theme, In Service of Better Health. We're here at a time of great uncertainty, great possibility, and great hope for a future, where everyone in every community can obtain better health. At times of change, one can be paralyzed by inaction or look only inward. But as I look around this room, I am inspired by the creativity, the dedication, and the shared purpose toward the much larger aspiration of hope. Hope demands a response. Hope pushes us toward action. Hope calls us to be of service. As leaders in life sciences, academia, industry, policy, patient advocacy, and finance, you are a beacon of hope. We will discuss enormous challenges during the summit. Health spending continues to rise. Between 2022 and 2023, overall health spending in the US rose 7%, and it is projected to rise another 4.2% in 2025. Health outcomes remain poor. In 2023, US life expectancy nearly returned to pre-pandemic levels, but still lagged in comparison to peer countries by roughly 4 years. The chronic disease epidemic is driving increased health expenditures. How we integrate food and nutrition will fundamentally define the future of health and chronic diseases. Populations continue to age around the world. 7.2 million Americans are now living with Alzheimer's disease. 300 million people worldwide are living with rare diseases, facing limited resources, the market failure in drug development, and high costs financially and emotionally for their family. 1 million people die around the world each year due to the consequences of antimicrobial resistance, affecting everyone at every life stage. 63 million family caregivers in the US, including 5.4 million children under 18, face financial, physical, and emotional strain without the support they need to protect their own health and well-being. We face disruptions to funding in global health and cuts to overall science funding. Mental health conditions are projected to cost the global economy $6 trillion by 2030. Americans lack access to clinical research and never participate in clinical trials because they are never asked. The trials are not designed with them in mind, or they simply live too far away. Women are often misdiagnosed, their conditions understudied, their ailments are often dismissed, resulting in women on average spending 9 years in poor health. Despite these challenges, and they are a number, we have possibilities within reach, more possibilities within reach now than ever before. Personalized medicines, liquid biopsies, technology-enabled care, innovations in gene editing, AI, precision nutrition, GLP-1s and strategies to address full cardiometabolic health, employers addressing whole person health as a business strategy, a healthcare workforce transforming primary care through the work of community health workers and nurse navigators, and the list goes on. We're living in a highly disruptive era, but with disruption comes the opportunity for transformation. This year, I engaged with many of you across our work, across Milken Institute Health, to advance solutions in biomedical innovation, public health, healthy aging, and food systems. This work is reflected in our reports, including 9 publications we're pleased to release at this year's summit. A key report is focused on the future of US biomedical research and innovation. We engage with over 100 leaders in key actions to maintain US competitiveness in biomedical innovation and present 6 recommendations to help chart the next era of breakthroughs. In May, we launched the Milken Institute Women's Health Network, chaired by Dr. Jill Biden, as a global collaborative designed to increase private sector funding and break down the barriers resulting in poorer health outcomes for women. We have welcomed 111 member organizations, and we are continuing to grow. I've had the opportunity to travel around the world and meet with many health leaders. There is a thirst for collaborative spaces to solve problems. And that is exactly what I hope you will find at the Future of Health Summit, a place to meet new people, form new connections, and engage in conversation. Over the next 2 days, you will hear from more than 200 speakers across nearly 60 sessions covering a broad range of health topics and have the opportunity to interact with 1,000 colleagues. I hope you walk away from this summit with new types of partnerships across industries and sectors, gather ideas for increasing efficiency and transparency in regulations and policy, and identify new priorities that reimagines the key principles of a better future of health. The U.S. has been a beacon of hope for the world. Let us aspire for greater possibilities. Let service drive our missions, and let hope be our guiding light. And to set the stage for our first plenary discussion of the summit, please welcome Joe Daly, Global Managing Director of Gallup's Public Sector Group, to share an overview of U.S. perceptions on health. Thank you and enjoy the summit.
Hello, everyone. As mentioned, my name is Joe Daly. I'm the Global Managing Partner at Gallup. Very excited, and thanks to the Milken Institute for having me here today. I think my assignment was simple. It was to set the stage with some data that Gallup has collected over time. And I think most of you know this, but Gallup has been in the business of collecting and reporting public opinion information to America for about 90 years. And I think, when you collect a data point, it's incredibly interesting. But what we have found is even more powerful is when you collect those data points over a time series. And you can start to look at what difference or what trends might be emerging as things change here in America. And so we've got some really interesting stuff on healthcare that we've collected since as far back as 2001 that I think paints an interesting picture. The first one is just simply asking Americans how they feel about the quality of their healthcare. And on its face, you would say 25% of Americans feel that they're getting quality health care. That would be one data point. But looking at a 10 percentage point drop over the last few years is very alarming. Similarly, we also ask Americans about how they feel about the healthcare system in America, whether or not how they feel it's doing. And you can see that during the pandemic, there's an amazing rallying to the healthcare industry, obviously as playing a central role in helping us get through it. But unfortunately, we've given most of those gains back over the last 5 years. Of course, healthcare as an industry is incredibly complicated. So we developed a metric about what we call cost insecurity. And there's a category of people that we consider to be cost desperate. Cost desperate would be don't have access, can't afford their care, and can't afford their medicine. And you see from 2021 to 2024, we've had an increase from 8% to 11%. You might go, Joe, that's not that interesting. But if you put it in people, it's 29 million Americans that we consider to be cost desperate. I think even furthermore, the data is more interesting sort of within the number. Or if you look at different racial or ethnic groups in America, they're experiencing way worse increases in cost desperation, similarly for the income situation in America. I guess that's all bad. I just want to share one positive, and for you guys, and then I'll get back to bad. Is the obesity. Obviously, it's a conversation in America about America's, the obesity problem, the obesity pandemic. You can see one really exciting thing is that the trend is actually moving down over the last few years for the first time in our tracking. And you can very clearly see that, in all the other stuff we track, Americans have not changed their behaviors. They're not working out more. They're not eating more healthy. It's 100% related to a medical innovation. And the increase in GLP-1 usage. And so this next slide, we actually ask about, using weight loss injectables in America, and you can see that, in a very short period of time, it's more than doubled. And we're seeing it doubling with men and women. So, and I guess kind of in closing, a couple quick last points to make would be, so where do we look for more progress? Where do we look for the fix? And I think two that at least come to mind for me are AI, and the other one is employers, as the largest providers of healthcare benefit plans and everything in this country. So just quickly, if you look at the AI question, as AI comes from what you might say the background of medical to the forefront with medical diagnosis, we just ask Americans, they remain really concerned about how AI is going to be used on the front lines of medical care. And so it's something we as leaders in the industry need to just be really aware of, that you're dealing with a population that is somewhere between concerned or worried about how this is going to play out. Second one, as I mentioned on the employer side, is that Americans very clearly tell us that they believe they don't believe employers should provide just benefit plans, but they really say they want to rely on them to provide quality health care in general. But you can see the yellow line below, 73% say that's the expectation, but we're falling way below that on the actual delivery side with only 29% of Americans. So one final point would be, as we all know, healthcare is experienced at the local level. Everything I've just shared with you is all national. So we're really excited with a partnership we have with the West Health organization. We have actually taken the access, quality, and cost equation, and we've taken that to the state level, and we're going to be releasing that data on November 18th. So if you're interested, make sure you're following along. Thank you very much.
Please welcome the panel on Leading the Next Era of Health, moderated by Bertha Coombs, Senior Healthcare Reporter, CNBC.
Wonderful to be here. It's a great crowd, and for those of you watching remotely, thank you for joining us as well. It's not a great note on which to start. It's when it comes to healthcare, it feels like we are in these Dickensians' best and worst of times. We have incredible treatments. People now can live with cancer as a chronic condition. GLP-1s are perhaps the most AI type of drug there is. There's so many new applications potentially, but the problem is access for so many people. So our panel today, I'd like to introduce Jeremy Davis. He is with US Health at Palantir. And Jeremy, tell folks a little bit about what you do.
Yeah, well, thank you for having me. It's great to be here. So I think if you break down the different ingredients to go from AI coming to the scene a couple of years ago to the U.S. health system or the U.S. government or the different parts of our economy actually creating a lot of value and improving upon itself so that everybody prospers. You have like the raw models, which there are many and they're getting better every day, and we're very excited about that. And then you have like everything in between to like install those models in a way that like delivers value for all the different institutions that make up our country. And you can think about Palantir's software product as the way to translate the large language model into those value accretive workflows. And then you can think of like the people at Palantir as we call ourselves forward deployed engineers who spend our time on the front lines of all of these different places in our economy and work with all of the very smart workers and health systems and insurance companies and beyond, and work together to figure out how to install these things that are value accretive.
Terrific, thank you. Next is Shane Jacobson, who's the new CEO of the American Cancer Society. Shane, tell us a little bit about you, and congratulations on
Thank you.
your new job.
Thank you. I was counting in days. Now I'm counting in weeks. So 8 weeks in, soon months and years. But I want to thank the Milken Institute for the invitation for the American Cancer Society to be part of today's discussion. At the American Cancer Society, our vision is to end cancer as we know it for everyone. And we do, thank you. A very talented team delivers on that vision through 3 pillars, we call them. One is patient services, being very close to the patient. And it's important to understand that at the founding of the American Cancer Society, it started with the patient. And I've been impressed by all the stories I've heard this week, how important, yes, that patient is to, of course, all of us. We deliver our vision and mission through discovery, through game-changing research. The American Cancer Society is the 2nd largest funder of cancer research in this country, behind the federal government. And 3rd, we have a very strong advocacy pillar, the American Cancer Society Cancer Action Network, who mobilizes at the state, local, and federal level with our staff and hundreds of thousands of volunteers that help us work towards that vision to end cancer as we know it for everyone.
Terrific. Next is Sarah London, the CEO of Centene, which operates in every government health market in this country.
We do. Thank you. I'll echo the thanks for having us. As Bertha said, Centene is very focused on government health insurance. We're one of the largest health insurance companies in the country, but uniquely focused on government programs. So we're the largest Medicaid managed care organization, supporting more than 12 million Americans. We are the largest carrier on the individual marketplace, or the ACA. And our focus in Medicare is really lower income, medically complex Americans. So that dual mandate of ensuring health outcomes and being stewards of taxpayer dollars is right at the epicenter of, I think, what you framed at the beginning of the challenges that we're facing.
And finally, Daly, who is the president of Jefferson Health.
Thank you, and it's great to be here. Jefferson is a large system in Pennsylvania, New Jersey, and Delaware, serving about 8 million individuals across 32 hospitals, and really uniquely positioned in this time where we have a world-class research institution, we have a health system, and we have mostly a government-funded health plan, and thinking through how research, care, and coverage could be combined in a way to solve some of today's major issues.
Terrific. You know, it's interesting when you look at the data from Gallup, or you look at any poll these days, people just are frustrated with our healthcare system. On the one hand, we know that we have some of the best clinicians, some of the best researchers, some of the best breakthroughs in the world, but people are frustrated because they feel that they can't access it. We spend more than anyone else on the planet, and yet we have the worst health span of major developed countries. So as we are in these interesting times, I wonder, from where you sit, where are we making progress right now? You're the youngest of all of us, so you don't remember the discussions back in '92 when everybody was saying, oh, HMOs are the way to go, and then people turned their backs on them and said, no, because I don't get access to my doctor with an HMO. They didn't want that. Then we said, having everyone covered under Obamacare is gonna solve the problem, giving everyone coverage. Well, people still, even though we have the lowest uninsured rate, people still feel like they're not getting access. Do you feel like AI is going to help us make progress? So far, what I've heard is mostly back office stuff.
Yeah, it's a good question, and thank you for calling me. I'm about to turn 30, which is very stressful for me, so that at least brings me some comfort. Yeah, but no, in all seriousness, I think, like, from my perspective will come from having spent 4 or 5 years like in health systems, looking at the workflows to get access, place patients, move patients along their care pathway, do all the back office stuff to get the health system paid, and so on and so forth. So I think from that perspective, in some ways I'm very optimistic that AI is going to have a big impact on all of the like subcomponents of reducing care, ensuring people can access that care, and when they do, that the care is really, really good. And then in some ways, I'm very pessimistic about it. And I think the ways I'm very pessimistic about it is that I think a lot of the discussion is that AI is like a panacea thing that's come to the scene that's going to automatically solve all these problems. And I think I'm sure Daly feels this acutely, where like the amount of like human ingenuity and entrepreneurial energy you have to put into looking at all of the different processes, looking at the workflows. How do patients actually schedule appointments today? Like, what does that flow chart look by that call center employee that actually gets them into the health system? And when they're there, how are the care pathways managed, and how are they discharged, and all of these different processes? It takes a lot of effort of some like very smart and entrepreneurial healthcare workers to figure out like how ought the models to be deployed against those workflows in the specific. How are we supposed to measure that it's actually working? How can we measure it in the scale of weeks, not the scale of months or years? And then how can we iterate really quickly? And so I think from that perspective, when folks are very committed to doing the work and solving backwards from some value outcome, yes, I think we're going to make a lot of progress. I think the thing, and then the optimistic thing there is there are tons of entrepreneurs littered throughout our health systems that are itching to go solve these problems. I think the bottleneck is like, how do we sort of close the loop between the people who understand these workflows, have the ideas of how we can make all these specific processes better, and start the work to actually implement them on the order of weeks and see if it works, and then go from there.
Probably one of the biggest obstacles must be financing this, because so many health systems are working with razor-thin margins. I worry that some of them are going to get left behind because they can't get in on this game.
Yeah, well said. I mean, healthcare financing and the rising cost of care, it's impacting everyone. It's impacting our patients and their families and hitting their pocketbooks. And also, healthcare institutions, doctors, hospitals, typically are the largest employers in a city, in a county. And it's very important for those systems to stay strong because they actually contribute a lot to economic development. I think when we think about AI, overlaying AI on a dysfunctional system is only going to either make those dysfunctions go faster. And so I always tell our team, we can't just do more with less, we have to do things differently. So the opportunity for us is, can we actually transform? Can we change the workflow? Can we change the way we're delivering care? And that does take people, process, and tech. And I think that's really the opportunity that we have, is there's a lot of change, so capitalize on that change. Try to do things differently. And because there's things that will be good using AI, and there's things that could be bad, where you can...
Have you been able to reduce some of the back-end work? Doctors having to spend pajama time going and finishing their records at home late at night, and...
We're doing all that, and those are like very positive. We do about 11,000 visits using Ambient, which is an AI technology, a week at Jefferson Health. And that's been very, very positive, well received, high net promoter score. On the flip side, with like Sarah next to me, it could be very easy to use AI to craft appeals letters now. And on vice versa, on the health plan side, denial letters. And so those are fundamental issues with our existing system that AI will just propagate further, unless you actually get to the core issue of, do we need that, or how does that work? And so I think that's the opportunity, is not just to overlay AI, but to actually reimagine the work to be better for patients.
I wonder about that. Dr. Oz has pushed for, voluntarily for the payers to bring down the rate of denials and to make it a seamless process using technology. But I wonder if it just creates a battle of the bots. The payer bot versus the provider bot, and they're still having the same fight.
Yeah, it is somewhat reminiscent of the Dr. Seuss like which side of the bread is, are you buttered on, and all of a sudden you're in like an arms race. And to Bali's point, AI on top of existing processes. Now, I don't want to knock the idea that there are trillions of dollars that we can take out of this system in the back end, right? Healthcare is a services business, and it is a regulated services business. It is a data-driven services business. It is a process-driven services business, which means absolutely there is huge opportunity for standardization, for automation. Now it needs to be sitting on, complete interoperable, consistent data. But AI should take dollars that we are all spending on those services and free them up to think about access differently, to think about coverage differently, to think about therapies differently. So I don't knock that. I think actually that's very exciting. But to your point, just taking existing processes and trying to drive higher revenue dollars by upcoding and trying to somehow manage the fact that this is going to hit the taxpayer pocketbook, that is not helpful. Now, I do think one of the other things that this administration has talked more about, which was not really as much a topic of conversation in the past, but is very real, is fraud, waste, and abuse in the system. And there is also a huge opportunity to pull that out of the system with AI and early detection of, essentially people who are, hanging out a shingle and falsely billing the government, and then they jump from state to state. But back to the point, we do need to think differently about how we work together. And this idea that if we want to actually make it possible for more providers to see Medicaid patients, we need to think about how to make it cost effective for them to do so. And for providers to have, Bali's got a huge back end operation that is people, process, and technology that's billing, and I have one that's adjudicating that billing. And like, really, if you're doing the right thing, like, why aren't these things somehow more embedded, connected, driving evidence-based decision-making at the upfront? That's where cost comes out of the system, decisions get made better the first time, and you don't have physicians who are using time in the day documenting, because they're really documenting so that you can bill, so that we can pay. You want them out seeing more patients. And that's the goal. And again, we also operate on razor-thin margins, but we're supporting people who, all of those, cost-desperate Americans that we heard about at the beginning, that we cover 28 million Americans, the vast majority of them are making less than $30,000 a year.
Your question about where can we find some silver lining and opportunity? I think innovation and AI, of course, present that. We've seen so much progress through research. The advances in research and discovery. Just in the space of cancer in the last 35 years, we've seen a 33 percentage point improvement in survivorship as a result of advancing, game-changing, cutting-edge cancer research. And those are talented scientists, many of them young scientists who grew up with new ideas and found people that would seed fund those brilliant ideas and were able to accelerate their ideas to fruition. But I'll give you an example of the overlay of research and the use of AI right now. We're funding a research project that's looking at colonoscopies. And if you haven't gotten your colonoscopy, a PSA real quick, please schedule it. So if you look statistically, the misses in the afternoon versus the morning of those performing colonoscopies, and the miss of the polyp is higher in the afternoon.
That's funny, because I always go first thing in the morning, because I can't stand having to do that and wait all day.
But my husband just did his, and he asked the doctor, how many of these have you done today?
Right. So go in the morning. It's small, very, very small. Talented medical professions connected here, but nevertheless, AI technology now that we're investing in is able to better predict and analyze the colonoscopy process and the polyps and advise those that are delivering the service. But I will also suggest that innovation and AI in a reactive model is moving us certainly at speed towards opportunity, but it's also missing the application of it, less reactive, more proactive on prevention and early detection. And that is where extraordinary opportunities exist for innovation. And truly, if that innovation at scale can be provided in an equitable way, then the innovation will really advance in ways that matter.
That's the question I was going to ask you in terms about equitable access. My father died of lung cancer. He was a 3-pack-a-day smoker in 1989. My mom had great health coverage. She did not wind up in debt back then. If it had been today, I cannot imagine what the debt load would have been, even with good coverage. And that is one of the things that I think makes people so upset about our system. Even if I have great coverage, with all of these new wonderful treatments, but they're so expensive, people wind up in debt, and then that makes them sick.
Couldn't agree more. For those who survive cancer, they're 2.5 times more likely to file for bankruptcy. 40% of cancers in this country could be prevented through personally modifiable behavior. We have distinct opportunity to address access at all ends of the continuum, certainly on the front end where there's important opportunity for this kind of collaboration.
I mean, that is so key, is with access, the word equity has to be in the same sentence. And it's not just population groups, it's geographies, it's all walks of life. With the new drugs that are coming out, the average cost on the market is around $300,000 is the new therapies that are coming. Amazing therapies. We're treating folks at Jefferson and being able to cure sickle cell disease, which is a very devastating and costly disease.
A $2 million drug.
A $2 million drug. So how do you think about that for folks that, for insurers that have to cover that, for employers that have employees that have those conditions, and also for, how do we make sure that access to care and care coverage is available to all? And those are really important conversations that have to be put together when we talk about scientific advancement. It's not good enough to just discover something new, but really think about how can people in this country and abroad access in an affordable manner. The medical debt is huge. It is a huge issue that is burdening not only families, but communities. And we have to figure out a way to address that. Because folks, what will happen is they will not seek care. So even the ones that did get into debt from, post-cancer, if you have another medical condition or heart condition, they won't come to care. And then that only raises the disease burden even more. And so figuring out how to triangulate those conversations are really, really important.
Sarah, you cover a lot of the people who are most desperate, and it's always a struggle to get providers, doctors, clinicians to take Medicaid patients. What are some of the discussions? Are there discussions? Because everyone knows this is a problem. Is there any progress in trying to get everybody onto the same page?
It's certainly a very active dialogue. I think going back to your original question, where are there bright spots? I do think that, coming out of the pandemic, a different way of thinking about what access looks like, and the idea that we can use virtual care, we can create leverage for the providers that we have. We're also trying to think differently about what the definition of a provider is. And so, thinking about, I have X number of OBGYNs, but what about doulas? How do I think about how a community health worker can actually walk a member journey in a more preventive focused way, so that I'm really only using my doctors when I really, really need them? And that, I think the points have been made. I think there is a big question about how we afford the system that we have created, and how do we think differently about, among insurers, as an example, pooling resources the way we did for Hep C drugs, right? Where we know something is curative, or we know something is really going to create a better outcome, a cost differential for the system as a whole. How do we solve for the fact that we are fractured in the sort of short-term impact, because the long-term impact is spread across that same taxpayer base, across that same risk pool? But it's also increasingly a question of, how do we build a health system, not just a health care system or a sick system? And how do we think about activating the community differently to care for folks, to get to them sooner, to help, influence around detection? Who are the individuals in a community that you can activate? And that's really our local approach has been trying to think about, how do you think about health first, so that you're thinking about health care only when you actually need to. And that, it's easy to say, it is very hard to do, because we have been trained in a consumption mode. We've been trained in as individuals, we sort of defer to the healthcare system around those decisions. How can we get a different level of agency? That's the other place where I think AI is going to be very interesting, is leveraging data to make consumers and patients smarter, so they can manage the first set of decisions and actually drive down cost. And that way you have fewer access issues. You're only going in when you really, really need it. And it starts to change sort of the cost equation.
This administration has touted making America healthy again. And there are programs that are already well underway in Medicaid and Medicare, food as medicine programs, trying to help people to understand how to eat better so that they can manage and perhaps even reduce their chronic conditions. But we're also, again, at a time of funding. So the Medicaid program is going to experience, once again, funding pressures because of the potential of more people being knocked off and disqualified. How do you balance, given that we are in this town and healthcare is a central issue right now in terms of funding it, how do you try to balance that and keep these programs going and working with states and health systems and advocates to help programs like food as medicine?
One of the things that I really like about, and Medicaid is very complicated, and every state's a little bit different, but the managed care model is not the same thing as group health insurance, right? We are given responsibility for a set of individuals in a given state, and our job is to provide access, quality outcomes, and savings and predictability from a cost standpoint to the state. So we are in literally that value-based formula in terms of how we operate. So we look at, for example, the investments that we make in food as medicine. We collect data, and actually, even in our most recent Medicare bids, we put in supplemental investment in food deserts because we saw that there was an uptick in health outcomes and medication adherence when members had access to healthy foods. So we are allowed to spend dollars that way. We are allowed to say, if I put $1 over here on health, it will actually drive the health care costs down. And that's the model I think that we should be operating in broadly, because it forces us to have really strong partnerships with our providers. It forces us to have really strong partnerships with existing community organizations that are already putting amazing resources around prevention and screening, and we help get members connected to those preventative screenings. That's, for me, when you think about what's going to happen with work requirements, our convening responsibility and power is something that we have to lean into to make sure that we are funding scholarships, we are actually training Medicaid members to be doulas, to be community health workers, to get, to create this sort of work requirement. We can do that in a way that will actually feed the system and maximize the number of Americans who have access to health care.
Ollie, you're nodding.
No, 100%. I think this is also an opportunity for collaboration. The more we go upstream, and we need to, like food as medicine, education as medicine, safe neighborhoods as medicine, those all impact people's health. We've all heard it, the zip code versus genetic code. But to go more upstream, it doesn't just rely on providers, payers. It is pretty much everyone on the stage and in the audience is how do we work more collaboratively to address those? If you're talking about food deserts, if you're talking about safe neighborhoods where people can actually walk and exercise, childcare, so individuals can actually come to appointments. It takes a community to do that, and we need more of that. And the more we're able to go upstream, and we have data on this both in this country and from abroad, those improve health outcomes. We also have seen a clear connection between primary care visits and health. And so the more you're able to actually get screened and have your annual physical and do all those important counseling, the more likely you are to be healthy and not deal with chronic diseases. And so I think that is also an opportunity. And I do think tech and also rethinking, as Sarah mentioned, the workforce. You don't need a nurse for all those. You don't need a doctor for all of those. So how do you think about different uplifting opportunities for those communities? And I think the community healthcare model is a perfect one where you're able to take folks sometimes from rural or impoverished communities, have them be empowered to help individuals with healthcare. Not only are you helping that individual, but also their block and their neighborhood. Those are powerful models.
Shane, is nutrition something that the American Cancer Society is working on, and can you help convince people that there's data there that this really works?
Yes. I'll give you a very real example, real time. We have a program at the American Cancer Society that will mobilize in times of great need. And given what we're seeing now with access to food being such a significant issue, we're getting ready actually next week to mobilize our program to allow Americans to submit a request for ACS funding to help them purchase food. And their decision—
To produce food or to obtain food?
Dollars to purchase food. And these are for those that are facing a cancer journey that otherwise don't have the resources, and they're making decisions, cancer care or food. Now, the American Cancer Society is not at its origin a nutrition, food-based charity, of course, on the surface, but we've made the decision that there's something we can do about it, and we have partners who are joining with us. So we fund through a foundation community program who are experts at delivering the dollars to the people who need it, who need to purchase food. So I think to the point of collaboration, asking ourselves, who are those partners that can add complementary services and programs because they are the experts, and then integrating our strategies across our enterprises where the effect will be multiplicity in nature.
Jeremy, a lot of people feel like technology could be the answer, although, again, I've been around longer than you, and I've been hearing that for 20 years, that, oh, we get this technology, it's all going to be great. One of the things I wonder about, though, is particularly the trust when it comes to agentic technology. We've seen that people have started to use some of these AI chatbots for mental health, and sometimes it doesn't work out great. I mean, just a show of hands, and if you're at home, raise your hand too. How many people have used a chatbot for health information? I have. I mean, I've used it.
Does Google count?
I think, yeah. Well, yeah, they have generative AI. I find that it helps to, especially when you get a report before you get a chance to talk to your clinician, to try to essentially interpret all the medical speech that you don't know. Is that ischemia bad in that MRI? And it wasn't so bad. How do we make sure that we can trust it? How do I make sure that when you're using it with a hospital, that it's not picking up personal data that I don't want it to pick up?
Yeah, it's a great question. I mean, I think there's two different parts of the trust. There's like the trust that the AI systems are actually going to work to improve the productivity in the health systems, to improve the quality of care, to, like, at the end of the day, the reason it's expensive, or one of the many reasons it's expensive, is because it's very expensive to produce it. And so I think, like, I'm very empathetic to the, like, will AI actually help with all of that stuff? And I actually think it goes back to one thing we was discussed earlier, where it was like, will all health systems or healthcare institutions be able to afford it? Because healthcare in the US is very spread out. There's lots of different groups with varying financial situations. And I think that mentality is very reminiscent of this, like, software industrial complex that honestly hasn't produced a lot of results for healthcare over the past 20 years. Like, when technology was really popularized in the 2010s, there wasn't an inflection of productivity. In fact, in a lot of ways, it's gotten worse. And I think the only way it's going to get better, like, the technology won't solve it. The only way it's going to get better is if folks like Sarah and Bali, which I think is happening, hold their technology partners and their AI partners to account on, this has been here for 2 weeks, have I seen value out of it? And I think there's this, like, learned helplessness where it's like, oh, well, I'm not supposed to see value in a month or 2 months or around the corner. And I think it's certainly possible. And then if that becomes the culture of technology and AI, I think we will see a lot of positive results on it. And then from the trust of, like, is it going to hallucinate? Is it going to give bad suggestions? Is it going to do something irresponsible with the data? I mean, there's a technical answer, to the question, where it's like, there are, like, technical components there beyond just, like, using ChatGPT to self-delivered healthcare. Like, my grandfather used to do it with Google, and it didn't work out so well. So it's like, we shouldn't do it with ChatGPT either. But
I don't know. Dr. ChatGPT or Dr. Perplexity are a little better than Dr. Google, I think.
Yeah, well, could be worse because you trust it more. I don't know. But but in any case, I think, like, there are technical answers to how do you, like, embed the right context, have the right human in the loop, have the right data privacy and protections, so that everything's done in a manner that works. And I think that's basically, Palantir founded a company around that. So I think it's a super important question.
So we're not going to get rid of people. I mean, I remember seeing, when you'd go to the hospital or a doctor's office, there was that person who would cart around the charts, from one department to another. That job went away. But boy, there's so many more jobs in the hospital that people need to do.
Yeah, I actually think there's a lot of reasonable fear around, like, jobs going away across our economy. I think there will be lots of jobs that change and get moved around. Like, I think that's just sort of will happen as in previous technological revolutions. I think the thing that brings me a lot of optimism on it is, like, the projects we've seen, like, we work with about 35 health systems across the country, and so we've seen maybe 100 different implementations over the past couple of years. And the ones that work really well are not the ones where it's like, okay, we're going to have the CFO in a lab with the AI provider and automate away 1,000 people. Like, those have been tried, and I just don't think they work very well, because it doesn't embrace the true complexity of all of these processes to get to an outcome and a product that actually works at the end of the day. And I think the better frame, which is, I think, optimistic for the value of AI accreting to the worker and making them more productive, is it's like, okay, who's your best employee? Who's your most entrepreneurial employee? And how do you build them the sort of, like, Iron Man suit with the right context, the right tools to make them 100 times more productive? And I think that tends to both work really well for, like, the bottom line of the health system and for the worker. And Palantir has a neat program called the American Tech Fellowship, where we effectively, like, bring in workers, educate them from the factory floor to the hospital floor, and help them understand how to use these tools to be more productive. And I think that's both going to produce the best outcome for the institution and for the worker.
Bali?
To piggyback on Jeremy's comment, we've thought a lot about AI, and I agree with him. I think it's not around, especially in healthcare and hospitals and clinics, it's not about taking out jobs, but it's really helping folks be more top of license. And so when we thought about how are we going to use it, we have more than 120 AI products in play. We came up with a bold commitment. And so we've committed to return 10 million hours back to patient care over 3 years. And that's how we're thinking about AI, which is, why should a doctor be charting? That is not top of license. 40 to 50% of a nurse's time is spent in front of a computer. we want to return them back to why they went into their profession, which is to care people, to help people. And so that's where we're focusing. And imagine.
And where are you on that journey?
We just started. We launched it about this summer, and we're using ambient first through with our clinicians, which is going really, really well. And now we're tackling the tough ones, which is really the nursing care in the hospital space. But what I will say is, it is returning. It's using technology to bring humanism back to care. And I think that's really, really important. We have so much tech that's being thrown at us, advancement. You hear about everything that's happening with social media and mental health. And really, the letters that I get, the phone calls that our doctors get are not about, oh, wow, you had the greatest robot in the OR. It was around, someone called me the night before surgery, or someone held my hand in the ER, or someone stood with me while I was having my chemo infusion therapy. It's the human contact. And so we can use technology, I think, in a way that allows us to humanize healthcare more. And that is that special intersection where we can start to figure out how to get people more excited about why they entered healthcare. And you can use the word productivity, or in my mind, it's more joy, because most folks do not want to go home and chart. And they do not want to be sitting in a cubicle typing. They'd rather be talking to a patient or supporting their colleagues. And so we're really, really excited about this initiative, and we'll have more data to share as we kind of progress through it.
We're sitting here as the shutdown is now a record shutdown in terms of how many days it has gone. So many issues that people are facing when it comes to the Affordable Care Act for middle class folks. They are up in the air as to whether there will be any kind of deal in time for a enhanced tax credit extension. And someone in the green room taught me a new vocabulary word that I think is very interesting. It's called apocalyptimism, which I love because it feels like our health system is so broken or on the verge of just teetering. There's so much distrust and unhappiness with it. And there are also concerns about some of the regulatory things that are happening that could result in some long-term things really being essentially destroyed. I'm wondering, as you look at this time, where do you find optimism that maybe this is an opportunity to think about building back better, building a system that people trust and really feel works for them? I know it's a huge question, but with the time we have left, I'd love to get your feeling about one thing that makes you feel like we could put this back on the path to something positive. Start with you, Bali.
Sure. I think just as you described, Bertha, we're in a special time period. And I think when we reflect back 5 years from now, 10 years from now, we're going to know that something was happening at this moment. And so for me, it's an honor to be at the table leading. And I think all of you in the room and the folks listening on the phone, this is an opportunity for us to make a difference. And it feels different, like to your point, it feels different than normal. And you could be all doom and gloom. And for me, I tend to be more of an optimistic person, which is how do we take this opportunity, never let a good crisis go to waste, and do things differently. And so I think it's an honor to be able to be in this time period, being able to shape healthcare in this country moving forward. And so I think if we have that sort of mentality where not the woe is me, we can't do anything, but we can do things. We can do a lot of things.
So where's one area that you think this is an opportunity to really shift?
I think one area is really around, as we think through the workforce, I think it's really, really powerful. In order for us in healthcare to deliver good healthcare, we need amazing people to do that. And I think both through upskilling with AI, thinking of professions differently than ever before. We have now new people coming into healthcare that were not jobs before, and then being able to get to people where they are. And I think that's a real opportunity. Folks don't have to go to a hospital, they don't have to go to a clinic, and they don't have to necessarily see a doctor or a nurse. And that is a different mind shift than 5 years ago, 10 years ago. And if we keep building on that, we might be able to unlock something special that we have not tapped into before.
Sarah?
I completely agree. I mean, it is a moment of revolution, and it's, I mean, part of the reason I am sitting in this seat is because I believe that it is incumbents who need to lean in and be willing to break things and be willing to do things that aren't necessarily even in our financial best interest, but are in the best interest of where we need to go. And this idea of a different workforce, and I would add to it and say, where I think we are going long term, and the inflection point that I believe data and AI can bring about, is solving the fundamental information asymmetry that is really what locks us in. And this idea that every single person in this room, you shouldn't just be a patient. The reason you all use a chatbot, the reason we all go on Google, is because the most trusted relationship you have is not between an individual and their physician, it's between you and the answer. You want to know what's going on and how to make it better. And the ability to empower more people to have more information, it changes the workforce. It creates a different level of agency in how we all make decisions. It allows us to think in a different way about how to empower community partners and other people who have specialized knowledge and information. And that, to me, is how you start to build a democratized health system, not a health care system. And I do think a lot of things are lining up in this moment where we could break some things and actually start to operate in a different way.
I would be remiss if I didn't ask you about this moment that we're in. We've begun ACA open enrollment. People are on tenterhooks, wondering whether there will be a deal. There's some discussion that now that the election is over, maybe that sort of lets some of the air out of the room, and there are people on both sides that are pushing for some kind of a deal. What's your view on it, and what happens if there isn't one for the enhanced tax credits?
I am hopeful and optimistic that something will happen before the end of the year, and it is partly because the reality is that, and again, our focus is lower income Americans. So even among those who purchase insurance on the ACA, we are predominantly supporting individuals and families who are making less than $50,000 a year. And there are millions and millions of Americans for whom they have a job, they're small business owners, they're low-income workers, they're in rural communities, they have graduated off Medicaid, and they have economic momentum, and they are contributing to their communities, and they don't even work necessarily for a job that gives them health insurance. So they're sitting in that gap. They are in a state that hasn't expanded Medicaid, and this is really a critical ladder in terms of that access to health care, which again correlates to all of these other positive outcomes. And so the facts of that, the political reality of that, there's certainly opportunities for reform, but I think that stability for individual coverage is really important. We have a hypothesis that that's actually how we're all going to purchase health insurance in the future. And so making sure that that chassis is strong and stable for our most vulnerable community members, I think, is the right thing to do.
One of the things that I still don't understand how, and particularly as the legislation was built, those of us who get coverage from our employers, we don't pay tax on that. And for the government, that's potentially up to $250 billion a year in revenue that they don't get because that is exempted. Folks who are poor, they get the tax credits as they should to be able to afford it. But folks who are in the middle class, are left out in the cold. They don't get any help, and they have to pay after tax. And to me, that's always seemed very unfair. So as people make this discussion, I always wondered, you have to think about the fairness of the tax fairness of this for different parts of Americans, different parts of our communities, different cohorts. But I'm not running for office. I'm just a simple journalist. That's just the way I see it. Shane, lots of things, especially there are people concerned about what's happening with NIH and with a lot of research opportunities. As you look, as things for some people are breaking down, where can we make things better as we build them back?
Yeah, there's opportunity, and I'm inspired by what is a growing level of interest in building affordability into our systems. And I would say, even backing into the conversations around AI, we have the chance to control, with the exception of maybe what's moving towards agentic AI, we have the chance to control building inherent affordability into the modeling that we create. And I'm inspired by the fact that this is a conversation we're attempting to accelerate on the front end. I'm inspired by the fact that we face grand challenges, and we're here today. We're watching and from home, and there's a clear sense, and I'm hearing it day in and day out, that the way to attack a grand challenge is to out-collaborate it and to find partners who are willing to go all in. We haven't talked about it much. We have a grand challenge facing us in rural health, rural population health. Just in the cancer space, for those Americans who are diagnosed with cancer and do not or cannot make it to an NCI, National Cancer Institute designated cancer center. Depending on their cancer type, they are between 30 and 70% less likely to beat cancer. We are committed to affordability. We are committed to access. So I'm inspired by the fact that we've identified the problems and we're interested in collaborative solutions.
And who are you finding receptive to this? You know, certainly this administration has talked about grants for rural health care, and there are a lot of folks who say we really need to build that up because there's so many people who are literally out there in the cold.
Yeah, the care delivery systems themselves, the cancer centers themselves are and have for decades been piloting programs. They're learning more quickly what works and what does not. I think the rapid nature and the speed by which innovation is allowing care to be delivered to communities and organizations like the American Cancer Society can help build those trusting relationships in communities to try to educate those facing this disease, try to educate those caregivers in communities who provide such valuable resources and care, that the innovation is there to help, the access is there to help, and the challenge for all of us then is through this collaborative ecosystem to deliver those solutions.
Is the lack of telehealth access for people in Medicare right now causing a problem for
it certainly is a concern. The American Cancer Society has a call center. So we are actually delivering a solution ourselves. We have for some time. I think the importance of it becomes even greater, where we have dedicated staff who are there to answer questions 24/7, 365. We've developed a new program to connect people who are interested in accessing a clinical trial, which are hard to understand. Where are they at? In what ways might they benefit me? We've created a new network framework that gives people the chance to lean in and help us open doors to access clinical trials, so that whether it be a telehealth strategy or otherwise, it's about being more creative to out-collaborate these challenges.
Jeremy, from where you sit, what do you think could help us get out of it? Can AI figure out how to create a better system?
I think it is unlikely to figure out how to create a better system, but I think it's likely to help smart humans create a better system. I mean, I think what your question made me think of, like when healthcare, or sorry, when software in the .com phase of technology was coming about. Like, it was sort of like fashionable to start a website that was like the third social media company and have the headline like, "We're changing the world," or "We're like making this big impact on the world." And then, 10, 15 years later, it was like became sort of like, it was still done, but it was sort of an unspoken joke that it wasn't actually going to have a big change in the world. And I think we're certainly at risk of that happening with AI, where like we're in the phase where it's fashionable to say that it's going to change the world. And I think it's sort of up to all of us and the folks who run important institutions, like on the stage today, to say, okay, we're going to ensure that it creates value. And I think there's a big fundamental shift that needs to happen in like, where does our young technology talent go work? Like, of the past 10 or so years, it's been like fashionable to go to Google or Instagram or things like that to like make social media better.
Or TikTok.
Or TikTok, as same idea. And then, and I think there's very few smart people who are like spending their time at Jefferson Health or Centene, or not few, but few compared to Facebook, Google, et cetera, who are just obsessing over how do we solve these problems and make it not a joke that AI is changing the world in 10 years. So,
I wonder about that. Obviously, every phase of communications democratizes people's ability to communicate their ideas. But what we have seen, and certainly over the last 5 years, on TikTok, the influencers gaining so much more validation than people who are actually in the healthcare system. Is that part of also what you're thinking about as you look to rebuild trust in our system? How do you, I don't want to say combat it, but how do you collaborate in that space now?
Well, part of our strategy is to lean into the influencers, and in our case, as is likely true throughout this room, everyone has a cancer story, family and friends, and these influencers do, not surprisingly, as well. So for us, I know we're close to out of time, I would say on our end, and many charities' end, it's to lean into the influencers who can help tell the story. Frankly, the messenger matters, because the messenger can deliver that message in ways that can, from time to time, be more trusted, and can communicate in ways that bring more diverse audiences to the table as a result of who is communicating.
Yeah, I think it's important on healthcare. You have the macro, which is, as we saw in some of the Gallup data, some of the trust issues. But still, when you get into an office, that trust, it remains very, very high between a patient and a doctor and a patient and a nurse. They're still two of the highest trusted professions in the country. And so it is a little bit of this dichotomy where, on the whole, people are skeptical. But when they talk to someone, and if it's endorsed or if it's promoted, they listen. And so I think as we continue to use AI and tech in our day-to-day life, and as it gets more incorporated with our clinicians, those conversations become really important, because that is also where you can start to change trust, kind of one person at a time, as our caregivers say, no, yeah, that's okay, or you should use this, or you should give this a try. That matters. Those voices still are very important.
And Sarah, we know that people don't like insurers. They just don't. How do you try to engage them? I mean, do you bring around patients who, members who have been able to have successful stories and help them engage others?
Yeah, I think this idea of who are the influencers, and there are obviously social media influencers, but physicians and clinicians are huge and credible and important influencers. And so we think about, how do we empower and amplify the influencers? There are also really, really important influencers in the communities and in the communities we serve. It may be a pastor at the church who is the person who can communicate that the cancer screening is the most important thing you need to do. And so rather than trying to, the hubris of, we're going to tell you, it's instead, can we provide data? Can we provide the right support? Can we provide a platform for those who have the trust and who can deliver the messages that we ultimately are responsible for helping to deliver, which is how do we get to health outcomes? And then I think also having, again, in the communities we serve, the Medicaid model, we are very local, we are very hands-on, we have very direct relationships with patients, and we have, unbelievable stories about what the Centene, we have 60,000 employees, and they are mission-driven to their absolute core. And we have team members in Arizona who, are care managers. They're taking care of folks who, are out on the reservation. There was a huge dust storm that came in and just completely made the roads impassable. And they borrowed a friend's, four-wheeler ATV and drove to the pharmacy and got the patient's medication and took it out to their house. And that's the kind, and that providers do that all the time. So we think of ourselves as, our responsibility is access and care. And I do think that, insurers are facing a difficult reputational framework in this moment, but ultimately what we are trying to do is put all of our resources behind those things that work to make people healthier, and we are trying to help support a system that we all have to pay for, right? All of it comes back down to taxpayer dollars. And so trying to make sure there is no waste, that there isn't fraud, that we are driving to the best decision the first time, that we support telehealth access so that we get people to care. That's what my peers and I are all trying to do.
Can I offer one more?
We have 5 seconds.
Go fast.
Your leadership matters. Your ability to do what you do matter. So I want you all to pull out your phones real quick, if you could. A few of you have them out now, but if you could, everyone pull out your phones real quick. At home, do the same. Please, seriously, I'm very serious. There's an assignment right now to just pull out your phone. Open up your calendar. Do it as we go. Open up your calendar. Fast forward 6 months. Scroll 6 months. Go to the month of, what would that be? May? Grab a day in May. May 5th. Put a note on there to thank yourself. Thank yourself that if you're behind on your screening, that you went ahead and did your screening. Because your ability to lead in a healthy way matters greatly.
Great note on which to end. Thank you all very much.
Please turn your attention to the screens for a brief video.
We thank the following organizations: